Welcome, Dr. Wagle.
Thank you. Thank you so much. This is one of my favorite conferences of the year, and I'm so glad that I'm able to be part of it this year, albeit virtually. And I'm really looking forward to this topic today. And so I'm going to give about 25, 30 minutes or so discussion on personalized medicine and the role of testing in metastatic breast cancer, followed by plenty of time for Q&A and discussion. So I encourage you to type questions along the way. If I happen to see something, maybe I'll even answer it along the way, but we'll certainly have time at the end to address. And I'll say something also about the topic. This could be a really huge topic, personalized medicine and the role of testing in metastatic breast cancer. I'm going to specifically focus on the role of genomic testing in metastatic breast cancer, not any kind of testing that could be done. And I will talk in a little bit about what I mean by genomic testing. So before I get into this, I will show my disclosures. These are my disclosures. And then let's get into some definitions. So first, I want to define a gene. A gene is the functional and physical unit of heredity that's passed from parent to offspring. Genes are pieces of DNA, and most genes contain the information for making a specific protein. And we have tens of thousands of genes, and each one has a specific role. And they are important for everyday function of our bodies, but they are also particularly important for the growth and development of cancer. The genome is the collection of all of the genes in any given organism, a plant, an animal, or a person, or a tumor. And the genome contains all the information needed for a person to develop and grow, and almost every cell in a person's body contains a complete copy of the genome. And the genome consists of, in a human, 20,000 approximately genes. Genomics, when we talk about genomics, we are talking about the study of this genome, study of the complete set of DNA, including all 20,000 genes in a person or other organism or tumor. And then the question that comes up all the time, genomics versus genetics. There are lots of ways that people have defined this. One definition is genetics is the study of genes, genomics is the study of genomes. But I would say, and for the purposes of this talk, and what I think actually people should have in their minds in general, is genetics and genomics are largely overlapping terms, and distinguishing them is not critical. And so we are going to be talking about personalized medicine and the idea of genomic testing or genetic testing, specifically of tumors, in order to help define people's care. So how do we do that? Well, the other distinction I want to make is this idea of germline genetics or germline genomics and tumor or somatic genetics, because these are two very different concepts. They're related, but they have very different implications. So germline genetics is when you look at the genes that you carry with you from birth, the ones that you inherited from your parents and are encoded in all of the different cells of your body. And this is typically done by a blood test, sometimes a saliva test, looking at normal cells, not cancer cells. And this is how we find inherited gene mutations that increase the risk of developing cancer. Things like BRCA1, BRCA2, PALB2, P53, CHEK2. These are genes that these are mutations in genes that one is born with and that are present in all cells in the body, including tumor cells that may develop. Now, in contrast, somatic or tumor genetics are found when we test tumor cells. And we can test tumor cells either by looking at a tumor biopsy sample or surgical specimen after the tumor is removed, or more recently, by liquid biopsies. I saw there was a question in the chat. Liquid biopsies, which is looking at a blood test, but looking at a blood test specifically to sample pieces of DNA or cells that are floating in the blood that came from the tumor, not from the normal cells in the body. And these, when you look at somatic or tumor genetics, these are genetic and molecular alterations in the tumor, not the normal cells, but in the tumor, that lead to the tumor formation and help, when we understand them, with diagnosis, prognosis, or treatment. And in breast cancer, these are genes like PIK3CA or ESR1 or AKT1 that are mutated or dysregulated in the tumor, but not in the normal cells, and one isn't born with them. And then there are some, like BRCA1 and 2, which can be mutated both in the tumor and the germline, or just in the tumor. And so there are some that are on both of these lists. For the purposes of today's talk, we are going to focus on somatic or tumor genetics. We could spend many hours talking about germline genetics, but I'm not going to focus on that here. Today, I'm going to talk about personalized medicine by looking at somatic or tumor genetics. One more set of definitions. How do we understand tumor genetics? We do it by conducting tests, often called sequencing tests, that help us read the genome of the tumor cell. There are a number of different tests that can be done. Whole genome sequencing basically looks at every piece of DNA in a tumor cell, all 3 billion letters, and it tells you everything that you could possibly learn about the DNA in that tumor cell. Whole exome sequencing looks at the genes themselves, because most of the genome does not encode for genes, but it contains lots of additional information, or in some cases junk, or in many cases things we don't understand. A portion of it, 1%, accounts for the genes that we know and are interested in. So that's 20,000 genes. It's 1% of the genome. And when we want to look at all of those, we use a technique called whole exome sequencing. Now, most of us, when we talk about reading the genome, when we talk about testing our tumor, we're talking about something even smaller. We're talking about a panel test. This is the kind of test you might get from your cancer center or from companies like Foundation Medicine. The panel tests look at the base pairs in a predetermined set of genes, not all 20,000 genes, but maybe 100 or 200 or 300 genes that are the ones that we know most about and we think have the most clinical relevance for cancer care. And so I'll get to this later, but knowing what type of testing we're talking about is important, whether it's whole genome sequencing, which is everything, whole exome sequencing, which is all of the genes, but only 1% of the genome, but the vast majority of which we don't really know how to interpret or what to do with, or panel tests, which are really a minuscule fraction of the overall genome, but really in the stuff where we think we understand the best and has the greatest implications. And for the most part, when we talk about reading the genome in cancer for patients, we're talking about panel tests. So what is cancer precision medicine? Cancer precision medicine is the use of all of this information, clinical, pathological, molecular, and genomic information, to come up with a treatment plan and direct the appropriate therapy to the patient at the perfect time. Another way to think about this for tumor testing and cancer precision medicine is finding and exploiting the Achilles heel of every individual's tumor. So what we're trying to do is we're trying to characterize each individual patient's tumor and find the vulnerabilities in that tumor, and then targeting or exploiting those vulnerabilities with specific drugs. So that idea, the precision medicine hypothesis, the precision medicine concept, and finding the Achilles heel of every tumor has represented this very important paradigm shift in the way we think about and treat cancer over the last 10 to 20 years, where we have shifted from thinking about cancer just in terms of anatomy, lung, breast, prostate, colon, brain, and including the key molecular features that we understand might be present in any given patient's tumor. And then once we know that key genetic information, picking the appropriate drug that targets that genetic mutation. And so that shift has been catalyzed by a few things. One, it's been catalyzed by research that has helped us understand mutations that might be present in any given tumor, and you see some of those listed here. It's been catalyzed by the development of rational therapeutics, drugs that are designed to target these mutations when we see them. And third, it's catalyzed by the development of genomic and molecular profiling techniques that now allow us in real time to be able to test a person's tumor or blood and actually figure out in that person which of these genomic alterations do they have, so that we can pick the right drug for them. And so this is an example from my research now more than 10 years ago, not in breast cancer, but in melanoma. But I use it because it highlights the concept so much better than any words can. This was a 38-year-old man who had metastatic melanoma, and you can see he had deposits of melanoma all over his upper body. Nothing was working. He was trying all sorts of experimental drugs at the time. We did a test on his tumor. This was quite experimental at the time. We found a mutation. There was a drug in clinical trials that was right for that mutation. He got the drug, and his tumors completely melted and disappeared. He ultimately did, unfortunately, develop resistance to this drug, which is a different topic. But the point here is this is the dramatic response that we hope to get from precision medicine for every patient. Find the thing that's vulnerable in the tumor, have the appropriate drug, and get these kinds of incredible responses. So therefore, then the path to precision medicine is when someone has cancer, and particularly advanced cancer, like advanced breast cancer, metastatic breast cancer, we obtain a biopsy specimen of their tumor. And in addition to all of the things that we standardly do, radiology, pathology, when appropriate, we also run this kind of molecular test, a genomic test from the tumor to profile for key alterations in the tumor and use that to identify which drugs, either approved drugs or drugs in clinical trials, that might be most relevant for that patient's tumor. And that's the idea of cancer precision medicine using genomics. So this idea has now been tested and developed over the last many years, as I said, and we have increasingly gotten from the FDA approvals for a number of different classes of drugs that are approved in specific cancer types with specific genetic alterations that can be tested for. And you can see those here. And I'll highlight a couple of important points here. So one is for any given agent, like an ALK inhibitor or an ABL inhibitor or a BRAF and MEK inhibitor, there is a particular genomic indication shown in the third column, meaning you test for that indication is what the then guidelines say when the guidelines say you should use this drug. But also, for the most part, these drugs are not approved in any tumor type that have these indications. They're still approved in specific tumor types. And that's because precision medicine has not replaced the need for understanding which tumor it is, it's just enhanced it. And so we have to know both the tumor type as well as the mutation or genomic alteration to know if there's a particular drug that's appropriate for them. So, and you can see on here, there are a few examples of genomic indications for breast cancer, but only a few. PARP inhibitors for breast cancers as well as other cancers with mutations in homologous recombination repair genes like BRCA1 and 2, HER2 inhibitors in breast cancer as well as gastric cancer with HER2 amplification, and PI3 kinase inhibitors in ER-positive breast cancer with PI3 kinase mutations. Now, there are two more recent exceptions to that rule where the only thing that's involved in the indication for the drug is the alteration in the tumor, and they're approved for any tumor type. And those are mismatch repair satellite high or mismatch repair deficiency or high tumor mutational burden in any solid tumor, the drug pembrolizumab is approved for, and a particular rare type of gene fusion called NTRK fusions, which occur extremely rarely in breast cancer, but they do occur. But any tumor that has an NTRK fusion is approved for these class of drugs called TRK inhibitors. And so we have two cases now, and maybe more coming down the pike, of gene tumor agnostic approvals for particular genomic alterations. But for the most part, these are specific to specific tumor types, and only a handful of them are relevant in breast cancer. And that's important when we think about what we might use personalized medicine and genomic testing for in advanced breast cancer. So now let's focus for the rest of the talk on metastatic breast cancer specifically. So if you get genomic testing of your metastatic breast cancer, either by tumor testing or by liquid biopsy or cell-free DNA testing? What can we do with the results of that sequencing today? Well, first, there are, as I mentioned, a few FDA-approved therapies in metastatic breast cancer based on the results of genomic testing. Mutations in PIK3CA indicate that you can get alpelisib or Piqray if you have ER-positive breast cancer. If you have mutations in BRCA1 and 2, that's an indication for these PARP inhibitors or olaparib or talazoparib in HER2-negative breast cancers. If you have mismatch repair instability or mismatch repair deficiency or high tumor mutational burden, you can get pembrolizumab. NTRK fusions, you can get these NTRK inhibitors. And so those are the four major ones that have been approved in various subtypes of breast cancer. But I will highlight that for the most part, our major biomarkers in metastatic breast cancer remain ER testing and HER2 testing. That is the major decision-making for what drugs we use, with these four other exceptions. Now, beyond these, there are a number of other ones that are suggestive of for drugs in clinical trials, and some of those are listed here: ESR1, ERB2 mutations, AKT1, FGFR1 and 2, other DNA repair genes, other tumor signatures. And these, when these are detected in tumor cells, might indicate that you are eligible for one of these clinical trials. There are also these trials called basket trials or umbrella trials, which allow you to test a tumor and, depending on what you find, assign you to one or more different drugs based on the findings of the test. Now, a common third option that's talked about, which I'll highlight here, is the use of off-label drugs. The ones that I showed a couple of slides ago that are approved in other cancers, for other cancers with different genomic alterations, but aren't approved in breast cancer. And there are anecdotes that one hears about of efficacy where there's a gene that's mutated commonly in colon cancer or melanoma, and it was seen in someone's advanced breast cancer, and then they got the drug that was approved in that tumor type, and it worked really well. And that happens. There are different ways that one can keep track of that, including a number of clinical trials, one called TAPER, the other called MATCH, which I would say are the preferred way to use these off-label drugs, because it's the only way we are learning and keeping track of them. And it's the way that we can do so in a standardized way, as opposed to using off-label drugs in an unregulated way. And so we can certainly talk more about that in the discussion. So for any given person, for all of you, what are then the considerations in getting tumor genetic testing? And I would say, from a practical standpoint, this is probably the most practical advice I'm going to give about tumor genetic testing. These are the questions that one needs to ask about tumor genetic testing when thinking about it. First, what are we talking about? What test are we talking about? What test are we talking about being done? Most of the time, we'll be talking about a DNA panel, a tumor panel, like they're available commercially. But increasingly, we might be talking about DNA whole exome sequencing, or even RNA sequencing, or some other novel types of sequencing, which are much more experimental and investigational. So what test is being done? Why is the test being done? So is this a time where there is no standard of care remaining and we are looking for clinical trials? Or is this a standard test that's being done in the first line setting because there is an available FDA-approved drug and you need to know if you're eligible for it, like alpelisib, Piqray? Third, what specimen are you testing? Are you testing a tumor biopsy, or are you testing cell-free DNA? Each of those has advantages. Tumor biopsies are the gold standard, what we've used forever, and often have sufficient material and have good quality control measures associated with them. Cell-free DNA is easy to obtain, and it might have some distinct advantages over tumor biopsies, but also has some important caveats and is newer. And so we don't understand how to use cell-free DNA as well as we understand how to use tumor biopsies. So that trade-off is also important. Fourth, when was that specimen obtained? So often when a tumor test is being done, it is being done on the original tumor biopsy that was obtained right at the diagnosis of breast cancer, but maybe that was years ago. And we know that breast cancer evolves. We know that the genomics of breast cancer change over time as tumors become resistant to the drugs we get. And so oftentimes it's valuable to test a more recent specimen, or even better, a current specimen, something that you are getting biopsied right now, or in lieu of being able to do that, a cell-free DNA specimen, which can give you the snapshot of what your tumor likes right now and not 3 years ago or 5 years ago or 10 years ago. Fifth, where is the testing being done? Commercial versus an institutional or academic lab. And again, there are pros and cons and caveats associated with each of these. Next, who is interpreting the results of the test? Is this test going to go to a doctor who has experience understanding the results of this test and understands what to do with it? Or is this test not getting interpreted by anyone and you are left to decide what to do with the results of the test? And then lastly, what are the potential options for acting on the results of this test? So a tumor genetic test is only as valuable as the options that are available for you to do something with those results. And if you have no access to clinical trials, or you have or there isn't some other thing that you think you will be able to do with them, and that's often something that's worth finding out up front, then the tumor genetic test is less valuable than if you know that you can act on this test. Those are a lot of questions, and I'm not answering them. I'm highlighting them because this is an extraordinary amount of information to think about. And I will summarize with kind of 3 take-home points. One is that as much as we talk about precision medicine, as much as we talk about genetic testing, I want to emphasize that most genetic testing and most genomic analysis remains investigational. And so there's a lot we can do, but a lot of it we don't yet understand enough of to know how to act on it. You saw that really there are only 4 drugs that are FDA approved. Everything else after that remains investigational. Second, there's a large variation in the quality and the interpretation of tests. So that's where it depends where you get your test, who interprets it, what's the quality, what was the quality of the tumor tissue and the blood that went into it. And then lastly, and because of all of these questions and because of this uncertainty and because of this large variation in quality, I would say that an oncologist or a medical team with expertise in the type of testing that you're doing is critical for understanding which tests to get and how to interpret them. This is really, really hard to do on your own. It's really, really hard to do even with your doctor if your doctor does not have expertise in this or understanding of this. And so figuring out who can help with this kind of information is really important. And for the field, both access to clinical trials and access to the various options to act on the results is critical and something we really need to work on. And second, education for not just patients, but also for physicians and everyone involved in the care to understand how best to use genomic testing is something that has lagged behind and something we really need to work on. And so if you feel confused about genetic testing, you're not alone. I'd say a lot of people are confused or find it hard, and sometimes because they haven't learned about it or don't know about it, but more often than not because no one knows the answer, because this is investigational and we're still learning this. So I'm going to give a quick primer on how do we think about these results. Again, not expecting that people should be doing this, but for those who are interested, when we get sequencing results, we need to think about a number of different things. We need to think about the technical issues. What was the quality? What was the depth of coverage? Was this a good test? Was this a tumor test? Was it a germline test? Was there germline testing done along with it? And then we look at 4 things. What gene was altered? What's the specific alteration in that gene? What tumor type are we talking about? In this case, metastatic breast cancer. And what's the context? What stage? What line of therapy? What else is going on? And the question any person interpreting these tests asks themselves is, what types of evidence support the clinical relevance of this alteration in this gene, in this tumor type, in this clinical and molecular context, and what is the strength of the evidence? And what we want to do is we want to find those options for every patient that have a big effect, that's going to do something regarding sensitivity to therapy or resistance to therapy or prognostic or diagnostic information, and a lot of evidence supporting it. And we want to weed out all of these things that are low evidence. And I think one of the challenges in precision medicine is that we often think about all genomic alterations as equally relevant or equally beneficial, and they're really not. Today, there are handfuls that are really meaningful, impactful, with good evidence, and most other things we don't know what to do with, and we probably shouldn't be acting on those outside of a clinical trial. And that's a big shift in the way many people are thinking about precision medicine. So the last few minutes, I want to talk about how we're going to move from this area where I say most of this stuff is investigational and we don't really know what to do with it, and how are we going to learn enough so that we can say in every patient, we know exactly what to do with your information because we understand enough. And the question is, how can we accelerate and improve research advances in precision medicine? There's been a lot of progress, as I've shown, but we clearly still have a lot of work to do. And what it will take to get there is detailed molecular and genomic characterization of many thousands of tumor and germline samples from patients, along with their medical information, so that we can see patterns in the data, we can understand the differences between different tumors. And along with that, we need to make sure that we are including underrepresented and historically excluded patients, because we don't have nearly enough data from all patients, but particularly from those who have been left out to date. There has been a lot of work over the last several years to understand the genomic landscape of metastatic breast cancer, and so we are learning more clearly. There have been studies from Memorial Sloan Kettering, from the Sanger Institute, from the Institut Gustave Roussy in France, the Netherlands, UPenn, Foundation Medicine, the Aurora trial. All of these are coming together to add to our knowledge of the genomics of metastatic breast cancer so that we can improve precision medicine. At our center, at Dana-Farber Cancer Institute, we've been conducting a big atlas in metastatic breast cancer over the last several years. We've collected 600 metastatic samples from patients with metastatic disease. And as I'll talk about in a minute, we're coupling that with a big nationwide project called the MBC Project, where we've collected already more than 600 tumors from patients across the country. And so we are doing a lot. We, the research community, are doing a lot to understand the genomics of metastatic breast cancer to improve precision medicine. And that's being helped by collaboration and data sharing. And you can see all of these different groups that I'm mentioning have done the important work of sharing their data, having it publicly available, making sure that we can all learn from one another. The challenge is that most patients don't go to those big cancer centers that are doing this research. 85% of adults in the US are treated in community settings, which means that most patient samples and most patients' data have not been part of those studies. They've not been readily available for study, for the simple reason that most patients have never been asked if they would be willing and interested in sharing their data and their information for researchers to accelerate this whole process that I'm talking about. And so when we started thinking about Count Me In, the idea was that technology and social media and cultural changes now provide an opportunity to engage cancer patients and directly partner with them in this research. And so the idea behind Count Me In is that every patient's experience with cancer should be counted, that every patient should have the opportunity to share their medical information, their specimens, and their voices with all researchers, not just if they go to a big cancer center, but all patients. And lastly, that every community, particularly those who have been historically underrepresented or excluded, should have the opportunity to participate in and contribute to research so that our research advances can reflect every patient and every community. And so with that in mind, we launched Count Me In, now going back several years, which says that every patient's experience with cancer should be counted. And you can see our website at joincountmein.org. And it's open to patients with metastatic breast cancer, but now is open to patients with all kinds, every stage of breast cancer, as well as any other kind of cancer. And I encourage you to check it out if you haven't seen it so far, or go to our virtual table. The oldest project in Count Me In is the Metastatic Breast Cancer Project, which we launched back in 2015. And to date, over 6,000 women and men with metastatic breast cancer from all 50 states and Canada have joined. And so this is how we are trying to accelerate our understanding of the genomics of metastatic breast cancer and accelerate precision cancer medicine for patients with metastatic disease. We've had patients, patient advocates, and patient advocacy groups involved from before the project had a name, from the very beginning, in conceiving, designing, implementing, testing, and refining this project. You can see all of our advocacy partners here, and I'm happy to say that LBBC was one of our very first advocacy partners going back to 2015, and has really been an excellent partner along the way, and I'm really very grateful for that. So I'm going to close there. We have plenty of time for questions and discussion. I'll just close with this, one of my favorite shots of people participating in the project. And really, this is a patient-powered movement, and it's the way that we are going to, and I believe it's the way we are going to get to more choices for precision medicine for patients faster, so that we can expand beyond those 4 drugs to many, many more that we will use when people get genetic testing. So that's my last slide. These are the take-home points. 1, cancer precision medicine is the use of clinical, pathological, molecular, and genomic information to direct the appropriate therapy to the patient at the right time. Number 2, in breast cancer, there are an increasing number of precision medicine approaches for both early stage and metastatic disease, although many of the approaches in many contexts remain investigational. Choosing and interpreting precision medicine testing is incredibly complex. And when using such tests, I think the involvement of experts is critical. Serial biopsies, potentially enabled by the use of liquid biopsies, are going to help advance these new paradigms in precision medicine. And then lastly, large open databases of clinical, genomic, and molecular information are needed to advance precision medicine, and patient-driven movements like Count Me In may help accelerate this process. So I will close there. Thank you very much. I'm happy to chat and talk about any of this in more detail.
Great. Thank you so much for a really clear, informative presentation on a very complicated subject. Breast cancer advocates or people with breast cancer must become informed, and it is quite a challenge, but this really is very helpful. I want to thank you for your Achilles heel metaphor. I think that is really helpful, at least to me, and I hope to others, that each individual's tumor that has an Achilles heel will find out what it is and direct the treatment to it. But another point you also made is that precision medicine is somewhat aspirational at this point. It is not quite arrived. It has arrived in a few areas, and you've talked about those in breast cancers. Is that right?
That's right. I think that's a great way to say it. So the Achilles heel is one of my favorite metaphors, because that is what we're trying to do. We're trying to find specific vulnerabilities, whether that is what makes the tumor grow or some other mysterious vulnerability in every patient's tumor. But the truth is that today in 2022, in most people's tumor, we don't understand what that Achilles heel is. And so the aspiration of precision medicine is we want to be able to understand every tumor's Achilles heel, and we want to be able to have a drug that's available for that patient that can use it. And we don't yet understand every Achilles heel, and we don't yet have drugs to target every Achilles heel. And that's the aspiration of precision medicine. I am, for the last 15 years, have been a firm, true believer in precision medicine as the approach, the way that we are going to cure metastatic breast cancer and other cancers. But we still have work to do to be able to apply this to every patient's case.
Great. Well, I'm going to start with a pretty simple question, but should every metastatic patient be having genomic testing?
It's a great question. This question has become clearer over the years. When I would get asked that question a few years ago, the answer would have been, if you have access to clinical trials, genomic testing can help identify clinical trials that you may be eligible for. And that's clearly still true. But I would say now, because we have a number of these drugs that are FDA approved based on genetic testing, there is value for every patient to get genetic testing at some point in the course of their advanced cancer, because there are key drugs that are relevant. For example, if you have ER-positive metastatic breast cancer, knowing whether you have a PIK3CA mutation is important, because it determines whether you can get Piqray, alpelisib. If you have advanced breast cancer and you have a BRCA1 and 2 mutation and you haven't been tested, well, that opens up the opportunity for olaparib or other PARP inhibitors. And then there are these extremely rare subsets. These are patients with NTRK fusions or high tumor mutational burden. And the likelihood that someone with breast cancer, with advanced breast cancer, has those is really low. And yet, if you do have them, there's a drug that might work really well for you. So I hesitate from saying fully that every patient should go out there and get testing, because it's not so easy today. Not everyone has access to testing. Not everyone can afford testing. Not everyone goes to a cancer center where testing is easy or easily interpretable. But I would say that every patient with metastatic breast cancer could benefit from genomic testing. So if possible, it would add to the information to help decision making.
Okay, lots of questions coming in. Should let's see, a lot of questions on liquid biopsies, and people are wondering, do they work for every MBC patient?
Liquid biopsies, yeah. So let me talk a little bit about the history and the concept of liquid biopsies. So liquid biopsies came out of actually prenatal testing. For anyone who has done any kind of prenatal testing in the last many years, you may know that now, instead of old, more invasive technologies, we can detect DNA from a fetus in a pregnant woman in the bloodstream by doing a blood sample, and you can actually do genetic testing on a fetus based on that blood test. And one thing that was observed when those studies were being done was that in a small subset of patients, it turned out they found cancer. They found cancer DNA when they were doing that prenatal testing. And it turned out that those women had cancer, unknown. And what was determined at that point was that tumors actually also shed DNA into the bloodstream. And there's been a whole industry over the last maybe decade or so trying to figure out how we can take advantage of that fact. The fact that tumors in the body shed DNA into the bloodstream, that we can sample it and we can identify mutations in that DNA without having to biopsy the tumor, has huge promise. And so now there are a number of commercial tests available, as well as experimental and investigational tests, where you can draw a blood sample, which is often called a liquid biopsy or a blood biopsy. And you can look in that blood biopsy and you can separate out DNA that comes from normal cells and DNA that comes from tumor cells, and you can do some sort of profiling. You can't get the same information from that blood sample as you could if you biopsied the tumor, because you can't test for things like ER status. You can't test for things like HER2 status. You can't test for other things like PD-1 or PD-L1 that you might need to use to choose an immunotherapy in triple-negative breast cancer. But you can see a number of things. And so people are increasingly using liquid biopsies to know if they have a mutation like PIK3CA for PIKRA, or AKT1 or ESR1 for other clinical trials. And it's extremely powerful. And in some cases, it might be more powerful than doing a tumor biopsy, because whereas a tumor biopsy, you have to pick one tumor. If you have multiple tumors in your body, you have to pick one tumor and you do a biopsy. You get one snapshot of what's in that biopsy. A liquid biopsy, since it's in the blood, presumably is integrating all of the information from all of the tumors in your body. The reason I said it's a little bit less ready for prime time is that there are a number of caveats with liquid biopsies that we don't quite understand yet. Those include sensitivity. So if you get a normal liquid biopsy, that doesn't necessarily mean that you don't have mutations. It may just mean that we didn't detect it, right? So there is a limit, a greater limit of sensitivity of liquid biopsies than other kinds of tests. The other is specificity. So we know now that there are many more false positives in liquid biopsies than in tumor biopsies. So we see mutations from something called CHIP, clonal hematopoiesis of inconclusive. Now I'm forgetting what the acronym stands for, but clonal hematopoiesis for short. And we don't know if that is relevant to the tumor. It's not from the tumor cells. And in some cases, we might find mutations in the blood sample that aren't really relevant. They might be really present at a really low fraction. So I think liquid biopsies are part of the future of precision medicine, but I would caution that we have a lot to learn about how best to use these, because there are a lot of issues with sensitivity, specificity, and irrelevant information that comes from these.
Okay. someone said she has bone mets. What if they can't access the metastatic tumor on the bone?
Say that again?
Would a liquid biopsy be helpful for people with bone mets where it's hard
Yes.
to access?
Yeah. So one of the real benefits of liquid biopsy is when you can do a liquid biopsy and the choice is that or nothing, a liquid biopsy can be really beneficial. And bone mets is an extremely good example of that, when sometimes a bone met is really hard to biopsy. And even when it is biopsiable, sometimes you don't get enough tissue, or it's hard to profile. And so liquid biopsy can be particularly valuable then, because it allows you to do a test when you otherwise might not be able to.
Great, thank you so much. In terms of germline BRCA mutations, people heard that you can have them. Okay, let me ask this question. Is the eligibility of a PARP inhibitor based only on germline mutations, or can someone whose tumor has the BRCA mutation be eligible?
Yeah. So the FDA approval for those PARP inhibitors are based on germline mutations in BRCA1 and 2, but we have now increasing evidence that there are tumor mutations in BRCA1 and 2, even in patients who don't have germline mutations, that are likely to respond to PARP inhibitors still. And so there are some clinical trials that are ongoing that look at tumor-only mutations in BRCA1 and 2 where PARP inhibitors are being used. And so there's also the potential for off-label use there, but there are certainly clinical trials where that's an option.
Okay. Another question, someone who might have germline mutations that increases her cancer risk, is it useful to do somatic testing to look for tumor cell mutations?
Yeah, so I think those two pieces of information tell us different things and complementary things. And someone who has germline mutations that increase their risk of developing cancer, their cancer still has some Achilles heel. And that Achilles heel may or may not be relevant to the germline mutation. So in most cases, the tumor that arose because of that germline mutation. And so we might think we know what it looks like, but sometimes there's something else there, because tumors continue to accumulate mutations. And so I would say that the value of somatic testing exists whether or not you have a germline mutation.
Great. And let's see. There was a great question in here. I have to say the Count Me In project has been very powerful to the patient advocacy community. The fact that it is a partnership with patient advocates and anyone who will donate and participate in the project. Can you share any early findings from the project, and that will help others understand sort of what you're looking for and what you're hoping to gain?
Yes, sure. So Count Me In, the things that make the Count Me In Metastatic Breast Cancer Project relatively unique are a few things. One is that patients who are participating are coming from all over the US and Canada. And so there are patients from more than 1,700 different institutions participating, the vast majority of which are not NCI-sponsored cancer centers. So one is that the data that we are including and sharing is a non-overlapping set to what exists in the data that's already out there from big cancer centers. So it basically is adding more data to the overall pool. The second is that the type of information we're collecting and generating is unusual, in that we are collecting and generating detailed genomic and molecular information from the tumors. Pretty comprehensive, not panel tests, not just DNA, including RNA. We're doing a very, very deep picture of the tumor samples, which is not typically done. And then we're annotating that, we're adding that to clinical data from the medical records and survey data from the patients. And so it's a very, very deep and rich set of data that enables researchers to answer questions they might not otherwise be able to answer. And so that data is publicly available, and we continue to make it publicly available. So the kinds of things that we and others are looking at, I'll give some examples. One, that data has been public as it's been generated. And so now there are more than 30 different scientific groups that have used the data, not related to me, the scientific groups that are out in the world who have used the data to have helped validate their hypotheses or make discoveries, and they've published papers. And so there have been a number of papers that have been published using Count Me In NBC Project data to help advance our understanding of breast cancer. One notable example is a group at UT Southwestern and Carlos Artiaga's group that used the data from the NBC Project to find a new mechanism of resistance to endocrine therapy in ER-positive metastatic breast cancer, because it was apparent there in the NBC Project data. And then this investigator went and he tested it in the lab, and it turned out to be real, and he published a really nice finding based on that data. We are now starting to look as a whole at the hundreds of patients in whom we have data. And there are a couple of key questions that we're looking at in my team. One of them is, are there differences in de novo metastatic breast cancer? So we have a lot of patients in the NBC Project who were diagnosed with de novo metastatic breast cancer. And that's a very understudied subset of advanced breast cancer. And so we have now identified a number of genes that are present in de novo metastatic breast cancer that look different than people who are diagnosed with early stage and recurrent breast cancer. And so we hope that this will help us understand something about why de novo breast cancer occurs, and maybe even something about how we might treat that differently. It's very early days, but that's another finding. A third one is young women with breast cancer. And so I have a longstanding interest in the genomics of young women with breast cancer. And in the NBC Project, we have over 1,000 people who are diagnosed with breast cancer before the age of 40. And so that's a huge subset of patients to be able to study the genomics. And we recently published a study looking at the genomics of breast cancer in 100 patients under the age of 35. And we found a number of important differences in their tumors that we think are relevant and potentially have implications for therapy. And now we can expand that to look at 1,000 patients who are young and have breast cancer. So those are the types of questions we're asking. We're particularly well-powered. This study is well-powered or well-poised to answer questions in rare subtypes, rare clinical behavior, like patients who have extraordinary responses to therapies, studying drug resistance. And so those are the kinds of questions that we're asking.
That's fantastic. People are wondering, are you putting these papers on the Count Me In website?
Yes. So some of them, selected papers are highlighted at joincountmein.org. We've shared some of them on social media, and as more findings come out, we will continue to share them. We hear almost every week from some research group who's using the data to answer some question that they're interested in. We couldn't possibly think of all the questions, and so that was why we took the approach of putting the data out there and letting people use it for whatever questions they're working on. And so there continue to be more, and we'll keep sharing them.
That's fantastic. Another quick question: does insurance pay for it, or are there any costs associated with the Count Me In testing?
No costs. So our team handles all of the work and the testing and everything. So nothing is billed. The only things that patients are required to do, we send you a saliva kit in the mail and a blood kit in the mail. The saliva kit, you can deposit a saliva sample in the comfort of your own home and drop it in the mail. Postage is paid, so that doesn't cost you anything other than the effort of providing the saliva sample. For the blood kit, we ask that you take it to your next blood draw, and there's a letter in there for the phlebotomist or the nurse or whoever's doing the blood testing, asking for a courtesy draw, and there's a FedEx packet, and then we ask them to drop it in the mail. So that's also no cost. The blood kit also can be taken to a Quest lab, and there's a voucher that comes with it, and you can get a free Quest blood draw and drop that in the mail. So all of those requires a little effort, no cost, and then everything else is survey-based online, and again, requires a little time, but no cost.
Great, thank you so much. That's really helpful. Okay, some people are not in areas where they can have an NCI cancer centers in the more rural areas. Is there anything, and they're worried about the quality and the expertise question that you said in your sort of take home, to get some expertise, how could you advise people to go about to find the expertise to look at their testing?
I think it's a great question. I think a conversation with your doctor at your place of care institution is a good first place to start, right? So a conversation around, should we be doing this testing? Can we be doing this testing? What are we going to do with the results? Some of those questions I listed. Which sample are we going to use? Which test are we going to use? I think getting some of that understanding is good. And then I think a frank assessment, a question or at least an impression of whether the person who you're getting your care from is comfortable with that, feels okay about it, wants to do it, and having an open conversation there is a good place to start. And then if it turns out that some additional expertise is needed, then I think there are a couple of different options. One is getting a second opinion at a place like a NCI Cancer Center, and now with telemedicine, some places are still doing telemedicine. That becomes a more realistic option than it used to be. It used to be really hard to do, but now potentially easier to do. There are some resources. Actually, Kathy, I don't know if LBBC offers anything like this, but some educational resources or networking resources to be able to connect to other people who have more expertise. And then some companies have molecular tumor boards, as well as some testing protocols. So ASCO Taper allows the doctor to plug into a molecular tumor board where experts sit to help make decisions. Some of the commercial companies also have molecular tumor boards with experts. And so I think connecting with one of these either academic centers or companies or trials that have access to experts who think about this is a useful thing if your doctor, your institution does not feel comfortable.
Great, great. Excuse me. Someone is wondering if any of the genomic research is on ILC. So,
yeah,
invasive lobular.
Yeah, invasive lobular cancer is one of those subsets where we have an urgent need to better understand the genomic and molecular underpinnings, because as many of you know, ILC is often treated very much like invasive ductal carcinoma, but we do know that there are differences both at the genomic and molecular level as well as clinically. These tumors metastasize differently. They have different responses to certain therapies, and so it's urgent that we learn more about ILC. And there's an incredible group of researchers focused on ILC, like Steffi Osterich and Matt Sikora and Otto Metzger, who are all working on ILC. There's an incredible advocacy group, affectionately I think known as the Lob Mob, and there's a conference and a research organization all working on this together. The Metastatic Breast Cancer Project in Count Me In is also working on this, but I would say in terms of the sheer effort and numbers of samples, these other researchers are where the bulk of this research is happening, and we're trying to help wherever we can. But I do think that precision medicine for ILC should and will be its own thing. I think ILC it's clear that ILC is its own distinct group, and we need better understanding of why ILC behaves the way it does and precision medicine approaches for ILC. Unfortunately, we don't quite have that yet.
Great. Thank you for that answer. People are also wondering how often, and you mentioned how often should they be tested and retested, as we know, cancer is sneaky.
Yeah, it's a super hard question to answer because it's impractical and also is associated with risks to do a biopsy every time you switch treatments, right? That's a lot of biopsies. That's where liquid biopsies come in as a potential really interesting and good option, which is maybe you have a biopsy early on and then follow on liquid biopsies where you understand what the baseline tumor looks like, but you can see changes over time, might be the optimal way to think about combining these two things. Again, cost is an issue. Liquid biopsies aren't necessarily free. Multiple liquid biopsies aren't necessarily free. But I would say repeat biopsy could be useful at the time you are thinking about a new clinical trial. I think an early biopsy in metastatic breast cancer is useful because it helps set the stage. I think a repeat metastatic biopsy later in therapy, when you've exhausted clinical standard of care options, whether you're looking at clinical trials, whether when the clinical trials have eligibility criteria that you need testing for, that's a good time to think about another biopsy.
Great. Well, I think we're just about out of time. It went very quickly, and I thank you so much for your great answers.